Welcome to Conversations on MS. We're streaming from lovely Broomfield, Colorado. Thank you to everyone who is attending here in person, and thank you to everyone who is online. We're here tonight to talk about MS with Dr. Andrew Wolf. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. If you enjoy the format of tonight's program, we have 2 more sessions of Conversations on MS coming up in October. Dr. Anna Shaw will present in Fort Collins on October 10th, and Dr. Enrique Alvarez will present in the Springs on October 29th. Both of these will also be live streamed on Zoom. I really enjoy hearing the different approaches to all of your questions, so I do encourage you to tune in and listen to some of the other doctors as well. It's fun. We also have a webinar coming up from Dr. Wolf on the use and misuse of stem cells happening on October 17th. And our Fall Education Summit will take place on Zoom and at Anschutz on November 16th. Topics covered there will include research updates, the possibilities of CAR T therapy, aging and MS, and managing invisible symptoms. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our educations are available to anyone free of charge. Let me introduce Dr. Andrew Wolf. Dr. Wolf attended medical school at the University of Denver School of Medicine and completed residency and fellowships at the University of Colorado. His research interests are focused on improving the treatment of patients with multiple sclerosis and other inflammatory diseases of the central nervous system. Current projects include developing digital and blood biomarkers to detect worsening in MS patients, characterizing clinical outcomes of neuroinvasive West Nile virus infection in patients on anti-CD20 treatments, and understanding the risks of immune checkpoint inhibitor use in patients with neuroimmunological disease. That was a mouthful. He's also interested in the acute management of demyelinating diseases and optimizing inpatient to outpatient care transitions. Just a reminder, we had a lot of great questions already submitted at registration. We're going to get to as many as we can tonight, but today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to Dr. Wolf.
All right. So thank you everyone for being here and online. So I think what we will do probably is to run through these submitted questions. And then if anyone has like an add-on question to these, please let me know and we can answer that at the same time. And then after we run through these, if you have anything that's come up that is not necessarily related, just let me know. We have plenty of time to answer questions, but thanks for everyone for being here. So actually, I think I'll start a little bit just going over a few things that are major updates in MS from the recent MS conference called ECTRIMS, which was last week. We often will see our major research announcements come out during these multinational meetings where people present on new clinical trials and things like that. So I think there's a few things that you may hear about, if you're following like the MS news on Twitter or X or Facebook or what have you. And some of these will definitely come up in the education events that are happening with the MS Center over the next couple months. So probably the most fundamental is we actually will have new criteria for diagnosis of MS. So dating back to decades, about every 5 to 10 years, groups of neurologists get together and develop a sort of schematic about how do we diagnose MS? What do you have to have on an MRI? What do you have to have on your spinal tap? What do you have to have as far as clinical symptoms to fit with a diagnosis of MS versus something else potentially causing your symptoms? And so, the sort of the framework of that has shifted, over many years to try to allow us to diagnose MS earlier and earlier as we've had treatments that are more and more effective at reducing attacks of the disease and reducing long-term disability, which is what we really care about. So the last iteration of this was in 2017. It's what we call the McDonald criteria. And so at the conference last week, there was a new framework that we at least got a broad overview from. And so again, it's moving towards more of what I would call a biological definition of MS as opposed to a clinical definition. So if we were to go back to say 20 years ago, it was not possible to get diagnosed with MS unless you had multiple attacks of clinical symptoms. With the 2017 revision, you could have one attack, and if you were thought to be high risk based on your MRI in your spinal fluid, you could still get a diagnosis. And now that is moving even further to including MRI and potentially spinal fluid findings, as well as some new MRI techniques. So you'll hear about something called the central vein sign. So that is a finding that shows up in MRI lesions for MS a large percentage of the time. And that helps us distinguish lesions or scars in the brain from MS versus other conditions. And then one that is called paramagnetic rim lesions, or PRLs or pearls. And so those are very specific for MS. So those will help us diagnose patients even earlier. So those criteria are not formally published at the moment. So, like most things, they'll be communicated in a paper that then the scientific community can review. And I'm sure at some point after that, we'll have an updated, education session in more detail. But really, this is trying to make it easier and more accurate to help with the diagnosis. So that was one thing. I think the other stuff as far as therapeutics from the sessions were that we may be on the cusp of having another MS treatment in the future. So there's been a number of studies looking at trying to modulate the immune system to reduce MS-related inflammation with what are called BTK inhibitors. So BTK stands for Bruton tyrosine kinase. It's an enzyme that lives in a lot of your white B cells, some of your white blood cells, as well as in a type of brain cell called the microglia. So we have a number of drugs at the moment, including drugs like Ocrevus that work on B cells. We do not have any drugs at the moment that work directly on microglia. So the thought is that microglia, especially for progressive MS, may be an important part of what is happening for patients. So these BTK inhibitors, there's been a number of different trials. But the one that was completed about 4 weeks ago, as far as the data analysis, was with a drug called tolebrutinib. And so that drug was studied as to did it reduce relapses or attacks that were causing MS symptoms in one study. And then it was also studied in what is called secondary progressive MS, where patients perhaps had had relapses in the past, were not actively having relapses for many years, but we're noticing that their MS was slowly getting worse over time. So in the study for relapsing MS, tolebrutinib was compared directly to a drug called Aubagio, also known as teriflunomide. So that is an MS therapy that's been out for over 10 years now. And that tolebrutinib did not look like it was any better or any worse than this older drug, Aubagio. So that was not really very exciting. In the secondary progressive study, tolebrutinib was compared to placebo because we don't have a lot of treatments for secondary progressive MS. It was compared to a sugar pill, essentially. And it looked like tolebrutinib slowed the rate of progression by about 30%. So that was promising. That is sort of a similar number to the benefit that we've seen from some of our other therapies for what we call primary progressive MS, like Ocrevus. So there's a lot more that we will need to learn about how these drugs work, what is their actual target, how well does the data hold up when we have all of it in front of us. But it does, at least with the overall result, look like it may be a promising new treatment. And then there are quite a few other BTK inhibitors that are still in active studies. So we'll be hearing more about these other study results over the next couple years as well. But something that might be potentially a very interesting option for our patients. The other clinical trial that unfortunately did not work out was the MS-STAT2 trial. So that was set up a little bit differently. So that was trying to reduce progression or the slow worsening in MS, basically by helping the brain protect itself and potentially help some of the myelin recover that we think is damaged in MS. So MS-STAT2 is using a statin, which most of you probably know someone that is on, or you may be on a statin, that are primarily used as cholesterol medications, and they're very effective at lowering cholesterol. But statins have a number of other pathways in the brain and spinal cord that they can act on. And the thought from some earlier studies is that they may help the brain sort of resist inflammation-related damage. That study was also done in patients that had secondary progressive MS. Unfortunately, though, it did not have any benefit in slowing down the worsening of patients. So it was a very well-designed study run over many years in the UK, but did not show a benefit. So I think, unfortunately, for that piece of like what we would term neuroprotection as opposed to anti-inflammatory medications, we're still without a lot of great options. But I think those were probably the biggest things as far as new drugs from the conference. We did also have some results presented from a study called Sopranino. So that was looking at Ocrevus, so one of the B-cell antibodies, and looking at amounts of that drug, both in the breast milk as well as counts for the B cells in babies that were born to people who were on Ocrevus. And so the reason that this isn't very important is that the average age of MS diagnosis in the US is about 30. About 2/3 of our patients are women. So we think a lot about sort of helping people achieve their family planning goals. And so, one of the concerns, of course, is the drug, safe to be on prior to pregnancy or during pregnancy, for instance. But another concern is just with the health benefits of breastfeeding. Is the drug safe to use for patients who are breastfeeding? And so those results were very encouraging. So we did not see any concerning safety signals for patients that had been on Ocrevus. And we also, saw very small amounts of Ocrevus in the breast milk, basically far, far below the level that we would be concerned about exposing a breastfeeding infant to. So that remains a very good option for us to effectively treat MS around the time of family planning. For those of you that know Dr. Shaw, she's been involved in those studies, just one of my colleagues at Anschutz. So.
Dr. Wolf, we did have a question from the audience to start off. What other conditions could cause lesions in the brain other than MS?
So that's a good question. So, a lot of lesions that we see on an MRI with MS are, fairly specific for MS, meaning that we, are very concerned that it's MS. There's not a lot of other things that can cause them. There are also a lot of lesions that often we're like, are we sure these are MS or not? And so those are things ranging from things that are not inflammatory, so migraine headaches being very common, high blood pressure can cause white spots in the brain like MS does, smoking, some more of those things that are related to issues with the blood vessels. And then there's also other inflammatory diseases that can often mimic MS. Now, those things are often much less common than MS is, but those are diseases like one called neuromyelitis optica, so NMO, and one called MOGAD, which is a newer description, is migraine lesions, just because migraines are so common. So the idea is that some of these new MRI tools will help us just be more confident in our diagnosis. Okay. All right, so let's run through, unless anyone in the room had any other questions about that stuff. Okay.
the one you sent the Skype
Yeah,
with about?
it's tolebrutinib, which is TOLEBRU, or sorry, BRUTINIB. Correct. Okay, so the first question that I had was, please talk about baclofen. I have muscle spasticity about half of the time, and I wonder if this would be an appropriate treatment option for symptoms. And so just to describe that a little bit, so spasticity is muscle tightening that we would say is more tonic. So basically your muscles feel tight all the time, and it's harder to like initiate movements or reach a full range of motion. Um, that is a very common symptom in MS that relates most often to damage or irritation of spinal cord pathways. So we have, all of our muscles when we move are getting a burst of like a positive signal to excite them. We also have, though, in our nervous system pathways, a inhibitory circuit that is trying to, slow down the muscles. And the reason for that is it helps us fine tune things if we have a positive and a negative signal. Those inhibitory circuits are very prone to being damaged from inflammation in MS, and that sort of loses that ability to relax the muscle all the way. So we see spasticity as a very common symptom. One way that is signaled in the nervous system is through what is called GABA. So GABA is a chemical that will bind at the nerve cell connections and basically make them less active. So baclofen is basically designed as a drug that mimics and binds those same receptors that GABA does, and then it can help you basically relax easier. So baclofen can be very effective for treating spasticity just by helping those circuits sort of work the way that they are intended to. So I use baclofen all the time for my patients. I think if someone has spasticity that only bothers them sometimes or only mild spasticity, there's a few different ways typically to think about that. So I do have patients that maybe notice spasticity being bothersome only with certain activities, like say they're doing physical therapy or something. In that case, it's very reasonable to take baclofen as an as-needed basis, as long as it is a small dose. I also have patients that just take it throughout the day to sort of give them that amount of relaxation all the time. But baclofen is a very safe medicine as long as you are not on a lot of it. If you're on a lot of baclofen, say over like 60 milligrams a day, you just have to be careful about not stopping it cold turkey because that can be dangerous. For instance, I would typically start someone on baclofen like either 5 milligrams as needed or like 5 to 10 milligrams 3 times a day. But it can be a very helpful medication. And that's not the only medicine for spasticity. So if someone's on baclofen and it's not helping, there are medicines like tizanidine, which is also called Xanaflex, and others that may be beneficial. Okay. The next question that I have, so it says, especially with the change of seasons, are there any recommendations for cold sensitivity? I get shaky in the cold, and I'm wondering if there's anything that I could be doing to help with that. And so, we most commonly see patients with MS that are very sensitive to hot weather. And that is one of the actually most described sort of phenomenon dating back, over 100 years as far as an MS symptom. Is called Youth-Hoff phenomenon, named after the neurologist who described it. And that happens because of basically the physics of how your brain and spinal cord cells are working. So, if you think about what's being damaged with MS, you have your spinal cord and brain cell like nerve fibers. They have a myelin coating on them. That myelin is one of the things that's majorly injured in MS, and then that reduces the efficacy of that signal transduction when the electricity in the nerve is basically, moving. Because of the physics, if your body temperature is elevated, so either from hot weather or you get the flu, frequently that will then make those nerve cells work even less effectively, and that's why frequently symptoms will get worse in those situations. So the same thing can happen with cold weather. It's a little bit less commonly described, but it is definitely possible that can occur. So the good news is that none of those situations are indicative that there's new damage happening. It's more so just that the older injury is being unmasked a little bit. So there's not really a way that like by, raising your body temperature, you're going to cause like new injury from MS. So how we deal with it, is predominantly environmental. So, for hot weather sensitivity, things like cooling vests, popping clothes in the freezer before wearing them before an activity, air conditioned environments are helpful. If cold sensitivity is a thing, the same sort of but reversed environmental things can often be helpful. I personally will use for my patients a drug called Ampera or delfampridine to help with heat sensitivity and potentially cold sensitivity. So Ampera has been out for several years, but it was a drug that was designed to help MS patients walk more efficiently. But what it does is it blocks some potassium channels in the nerve and it helps the nerve fire more effectively. So it is helpful for about half of our patients with walking speed, but it's not, it should work for anything that is caused by the nerves not functioning adequately. So I've also used it sometimes as a fatigue drug or a cognition medicine. It just is not technically approved by the FDA for those purposes. But if you're having really bad temperature sensitivity, that may be worth a discussion with your neurologist. Is a good question. Let's see. So the next one I got. So what dietary restrictions are there for patients undergoing infusions or injection treatments? What over-the-counter medications and supplements should be avoided while on treatment? And so there's not, I would say I don't have a lot of dietary restrictions for people who are on different treatments especially that are the monoclonal antibodies, so the drugs that are infusions or injections. Those drugs do not interact with much just because of how they're designed. So there's not a great reason to have to avoid anything. As far as supplements, I guess the one that we often recommend that has evidence for helping reduce disease activity from MS is vitamin D. You can find a lot of sort of comments, even in the scientific literature or on patient-focused forums about a whole bunch of other supplements, but most of those do not have very robust safety data or efficacy data. But vitamin D, we do know will potentially be helpful. There was a new study, again at Ocrevus, that was replacing or supplementing vitamin D in patients who had vitamin D deficiency. And that did look like that did reduce disease activity with MS. So that is often an important one for us to track. The next question I have says, 3 months ago, I began medical marijuana for spasms and spasticity. It has definitely helped. My balance, strength, endurance, and mobility have significantly improved. Is this simply due to reduced spasticity, or is there another mechanism, perhaps anti-inflammatory, occurring from the marijuana? I would say that it's hard to say for sure for that. So we know that different cannabis products will act on what's called the cannabinoid receptor, and so that is certainly involved in pathways that can cause spasticity and especially what are called nociceptive pathways or pain pathways in the spinal cord. So there's very strong like laboratory data that could be effective for pain and for spasticity. We don't know as much about anti-inflammatory properties. I think there's a lot of limitations as far as clinical research with marijuana products, just because there's a lot of regulatory issues as far as government funding. That has been a major sort of limitation with understanding how these things may work. But it definitely is, sort of an understudied area that we would love to delve a little bit more into. I know before my time, but we did a survey a few years ago after marijuana was legalized in Colorado, and about 40% of our patients had used some form of cannabis product in the preceding like 6 to 12 months that we're seeing at our clinic. But we definitely do not understand all of the therapeutic potential as far as mechanism. So something, definitely that we could delve more into at some point.
Dr. Wolf?
I know you said that vitamin D does have an effect to like lower inflammation. I think I heard that zinc does as well. Is that true?
It potentially does. So someone had also asked a question about glutathiones. There is a huge amount of literature out there as far as scientific studies looking at a whole bunch of different supplements. It's certainly possible that zinc might be helpful, but the only one that has completed like adequate, like well-designed clinical trials is vitamin D. So we're just not sure. Zinc is not probably one that is particularly like risk for harm. I think sometimes the issues with these supplements is like interactions with other medications, or do we know how safe they are? But yeah, it certainly has some potential. Okay. And I got a question that says, are patients with foot drop and leg weakness getting good results with BINS, psionic sleeve, and AFOs, and anything else that might be new? So just to be clear with that, so foot drop is when you will have some weakness with sort of bending the foot up like this. So the foot can often be hard to lift off the ground, will sort of slap a little bit at times. That's a very common symptom with MS, with damage in spinal cord motor pathways. BINS and psionic sleeves. So those are devices designed predominantly to help with leg muscle strength. And so they will sort of wrap around these areas on the leg and sense essentially when there's motion, and then sort of zap the nerve to help the foot, move up like it normally should. So the reason that those often are helpful is that MS does not impact the peripheral nervous system. So MS is a disease of the central nervous system. So the brain, the optic nerve that carries the vision back from the eye, and the spinal cord. The inflammation in MS does not target your peripheral nerves. So like this nerve, for instance, the median nerve, like running down to my hand, cannot be damaged by MS. So that whole pathway, if I have hand weakness from MS, this whole pathway often is still working. The problem is getting that signal down from the brain and spinal cord. So these devices aim to sort of co-opt the fact that this is still working, that if we were able to adequately like shock this nerve and make it work correctly, that we could still get, but with the foot, we could still get it to move appropriately. So those are newer devices. So I have only a handful of patients on BINS or the psionic neural sleeve, but they have a few patients have done very well with it. We typically, at least at our clinic, we have a specialized physical therapy clinic that patients can go and essentially try out the neural sleeve and see, is it helpful for them? Does it improve anything as far as their functioning? Before they decide to move forward with trying to get, payments for it, basically. An AFO, which is an orthotic, is sort of the older school approach to foot drops. It's like essentially like a brace that can help the foot, sort of stay in place. Those are often very helpful. They're much more accessible, depending on the type that you may get. They may cost several hundred to $1,000 versus the neural sleeve, which can cost several $1,000s plus monthly subscription fees. But the neural sleeve and BINS are much newer, more advanced technologies. The other one that comes up a little bit is something called the Sabo step. So the Sabo step is also a brace. It's like a little sort of like wrap around the ankle that connects into the shoe, and it can sort of hold the foot up if you're having a lot of foot drop. That is maybe the cheapest one. That is typically about $100 to $150. But all of those may be helpful in the right circumstance. Okay. Next question I have says, how should I best deal with fatigue? And so that's a very interesting question that there's a lot of different potential approaches to. I think one thing to always think about is we know that there is fatigue for patients with MS simply because they have MS, and that we don't totally understand why that happens. It probably occurs due to the brain and spinal cord cells just not working as efficiently as they used to before there was injury. But we also know that people with MS get fatigued for the same reasons that everyone else gets fatigued. So they're on medications that make them tired. They are depressed or have anxiety that's sort of distracting from their energy level. They're not sleeping well. Those are probably the biggest ones that I always talk through with my patients. Sleep is very, very important. And MS patients often do not sleep as well as people that do not have the condition, just because of things like restless leg syndrome, chronic pains, having to get up frequently to go to the bathroom, all of these things that will sort of interrupt your sleep. There are also much higher rates of sleep apnea, so basically not breathing correctly at nighttime with MS than with the general population. So it's very important to sort of, methodologically to approach each one of those things, like with your neurologist, and sort of address, is there sleep apnea that's not treated? Are we giving you too much Baclofen that's making you fatigued? So those are often very helpful. Once I have sort of addressed all of those, if there's still a lot of fatigue, then it's time to sort of talk more about like what are we intervening upon from like a therapeutic standpoint. There is not, perfect data about this, but there are increasingly included in different clinical trials for MS medications, looking at fatigue scores for outcomes. So drugs like Briumvi, which is a B-cell drug Dr. Alvarez was involved with, where we can see some improvements on fatigue scores for patients that were on that medication. We may see similar effects with other high efficacy medications as well. Like I had mentioned with Ampyra or Dalfampridine, I do have patients that take that drug sort of off label, that it helps with their fatigue. And then I do use more targeted medications for fatigue, like modafinil, for instance. So modafinil is aiming to sort of ramp up some of your attention circuits in your nervous system. So it can often be helpful for giving people a little bit of a boost if they're just really struggling with energy, whether that's from MS or sleep apnea or that sort of thing. Okay. The next question that I have says, what is the value or importance, if any, of a spinal tap with all the newer diagnostics and treatments? And so that's another good question. So we've not seen completely every aspect of the new diagnostic criteria. It does still include a spinal tap as an important component, but a spinal tap is by no means required to have a diagnosis of MS. If someone comes in and has symptoms that sound a lot like MS, they're in the appropriate demographic, meaning they're a younger patient, and they have an MRI that looks like MS, then a spinal tap is often not helpful for us. Although a spinal tap is not a terrible procedure, it is invasive, it does cost money, so we try to not do it if we don't have to. It is not required. Where we frequently will think about doing a spinal tap, is very early diagnosis. Let's say, someone's had one attack and has a very small amount of lesions. A spinal tap can often be helpful to basically look and see, is there inflammation that looks like MS that is present or not? And then on the other end of the spectrum, in patients that we may be concerned for an alternative diagnosis, a spinal tap can often help us make sure there's not something else happening that may mimic MS. So that has probably become more important for our older patients. And again, I have not, seen the exact full layout of these new diagnostic criteria, but the proposal was that for patients over 50, just because a diagnosis of MS is much less common as far as a new diagnosis, if you're over 50, that a spinal tap may be very helpful to help us be sure that we are looking at the correct problem and not some other, disease process. There will be, so we'll try not to get too far into the weeds, but traditionally on a spinal tap, our marker of MS is something called oligoclonal bands. That is not specific for MS, meaning other things can cause oligoclonal bands to be present in the spinal fluid. That is still one of the major things that we will look for, but there's also another new test that will be included, which is called kappa light chains. And so that, again, is just another marker of inflammation that we can see. It's a little bit easier for some laboratories to run that test, which is why it will now also be included. Okay, so the next question I have is it possible to stop Tysabri for a different drug and then restart it? And so Tysabri is natalizumab. Tysabri is a high efficacy MS drug. Tysabri is typically given as a monthly infusion. It basically will work by blocking inflammation from getting into the brain and spinal cord from the blood. So it's a good medicine. It's been out since 2004. I think probably the reason for this question, potentially if I read into it a little bit, is that although Tysabri is very effective medication, one of the issues with Tysabri is that if you stop Tysabri and it washes out of your system, you actually are at risk of having the MS like flaring up with what we call rebound disease, and that can be quite dangerous for our patients. So, in my personal practice, if I have someone on Tysabri and I'm stopping it, either because of their preference that they don't want to switch to a different drug for convenience purposes, or if there's concerns about side effects from the infusion or PML, which is an infection we can see with Tysabri, I will pretty much always switch the patients to a different high efficacy drug, usually a B cell drug like Ocrevus or Briumvi, Kesimpta, because those are very effective and have been proven in different studies to reduce the risk of that rebound disease happening, quite markedly. But it would certainly be possible to restart Tysabri. There's no reason that, let's say, if I create a scenario, you're on Tysabri, which is every month, you're going to go travel around the world for a year. It would certainly be possible to switch to a every 6-month infusion with like Ocrevus and then go back to Tysabri later. And that would be, certainly a reasonable thing to do if that was your preference. But there's not, anything that is preventing us from moving, back and forth between those drugs. Okay. So the next one I have, is there any new research regarding when someone who is getting rituximab infusions can safely conceive? Great question, and that gets a little bit back to some of what we talked about with Ocrevus and breastfeeding. The same sort of principles apply to rituximab, which is Rituxan, or some of you may be on some of what are called biosimilars, which are sort of like generic drugs for antibodies. So Ruxience, Truxima, Riobni, those are the other three that we often have patients on. So there's a big gap in sort of what most of us or all of us will do at our clinic at the university versus like what the FDA guidance is versus like what people may do elsewhere. And so because we have a very large amount of patients on these B cell drugs, we have a lot of experience with sort of timing them around pregnancy, and family planning is very important. The old school method of like, well, you have MS and we have you on drugs, you should never get pregnant is not really an adequate, like, patient-centered response. What I typically personally will do with these medications, so with rituximab, for instance, is I will typically have a patient who wants to get pregnant get an infusion of the drug. I will typically have them wait about a month, and then they can start trying to get pregnant. The reason for that is that the drug, typically is going to wash out following that strategy, even if you got pregnant immediately, by the time that the placenta and the fetal ability of the fetus to sort of transfer the drug, would make it in and potentially be harmful. So we do that, at least a few dozen times per year as far as timing in our clinic. We don't give infusions during pregnancy. It has been done in a number of other diseases. The reason that we don't do it is not so much about safety, but about the fact that it's probably not necessary, just because these B cell drugs like rituximab will work much longer than the every 6 months typically that they are given. I think that we can very easily sort of use these drugs in people who are planning to, try to get pregnant. In fact, these are the preferred option, in my opinion, for that situation. The next question I have is, what can you comment on about consistent, challenging cardiovascular exercise as a form of preventative medicine? And so exercise can be very, very helpful for patients. One, building strength can be adaptive as far as any deficits that people may have accumulated from the MS. Two, we know that exercise helps our brain cells communicate better. So when we have cardiovascular exertion, we release a chemical in our brain called BDNF, brain-derived neurotrophic factor, that will frequently help build stronger connections between the neurons in the brain and the spinal cord. So that can basically be a protective mechanism. And then probably equally important, we know that as people get older with MS, so into their 50s, their 60s, one of the major reasons that they get worse is that there's older injury from MS, but then there's added injury from cardiovascular diseases, things like high blood pressure, diabetes, high cholesterol, and things that all are reduced if people try to stay physically fit and participate in a regular exercise program. So that is also a big, driver, those same factors for things, neurological diseases that are not MS, like dementias, for instance. So I think it's important just to set the stage, just because we're in Colorado and everyone is, a lot of people are doing like crazy exercises. You do not have to be like, climbing, 14ers to get adequate exercise, even like, brisk walking the dog, riding a stationary bike at a reasonable speed, really just some amount of physical exertion can potentially be helpful. Next question I have is, do the locations of lesions on the MRI determine what symptoms you may experience?
And Dr. Wolf, can I also add, does the number of lesions correlate with severity of MS disease?
Okay. So the answer is yes and no, but it depends a little bit on where the lesions are. So we sort of work up the nervous system. All of our spinal cords are about as thick as my pinky finger. So it does not take a lot of lesions in the spinal cord to have symptoms. So, the area that we think of as being the highest risk for causing long-term problems from MS is like right at the top of the cervical spine, because all of your pathways to the rest of your body, except for your head, are running right through that space. So if we injure that area, we can see deficits in all of those downstream, spaces. In the spinal cord, your spinal cord is just a bundle of wires. So, it's often very easy to do a physical exam and then look at the MRI and have an extremely close correlation as to why that deficit is happening. That gets harder as we move up the brain. So we move into the brainstem, that often is still small areas that we can directly correlate to symptoms. If we go up to the cortex and the hemispheres, it would actually not be uncommon to have lesions that we cannot identify at all what the symptoms are, especially if there's very few of them. There is some correlation between number of lesions, anywhere and disability. But again, a lot of that's going to depend on where the lesions are. So if I had, 12 lesions or something up in my hemispheres, I may not notice anything, especially if they're smaller. But if I had one, lesion just in my cervical spine, that could certainly cause a lot more symptoms. So yeah, the answer is definitely the lesions in general are going to correlate. Our nervous system, all has sort of dedicated functions, but it is not, necessarily perfect, especially as we move up higher.
I had one more question from online. Is it true that MS flares happen approximately every 5 years?
It depends on the person. So it's a very, and the treatment. So it depends, a lot on the individual. There are people that are described as having what was used to be called, or still is called in some context, benign MS, where they get diagnosed after an attack and then basically like nothing ever happens again. I think if we look hard enough, that's a very small percentage of patients, if any, certainly less than 5%, in my opinion. But I think, we have patients that will have relapses if they're not treated, 5 times in a year. We also have patients that won't have any relapses over 5 years. I think, the question that you may ask is, well, why is that the case? And the answer is we don't know. There's just a lot of disease, just heterogeneity, for instance. That leads a little bit into the next question. And it says, does anyone have the answer to why people get MS, what triggers MS, why some people have it and others do not, even twins? And so, we all get diseases basically for 3 reasons. We have genetics, we have environmental triggers, and we have bad luck. And so, we know MS has a genetic component. It's not a particularly strongly genetic disease, getting to this point about twins. For identical twins that have the same DNA, what we would call the concordance rate is about 30%. So if one of them has MS, the risk for the other one is about 1 in 3. So definitely a lot going on that is not purely genetic. For first-degree relatives, which we're trying to learn more about with some studies at the university, they're called the RISE and DREAMS. For first-degree relatives, the risk, to put in context, is probably somewhere in the realm of about 8 to 10 times higher than the general population, but is still quite rare. So if we were to estimate, what percentage of people or what number of people in the US get MS, it's probably about, somewhere around like 1 in 300. If you have a first-degree relative that has MS, maybe around 1 in 30 to 1 in 40 of those people that get MS. So it still is very uncommon. So it's definitely is not a disease like some other diseases that we see in neurology where it's like a single gene and that single gene leads for someone to get the disease if they have it. That is absolutely not the case. We think probably that there are at least 300 or 400 genes that can influence the risk for MS. They all have different effect sizes as far as how risky they may be, but they also have what we would call incomplete penetrance, where sometimes they will increase risk, but sometimes not. So it's a good question. I think that it's getting to the environmental piece after the genetic piece. Something that has been of interest for probably 60 years now, but has been increasingly in the news and in the literature is Epstein-Barr virus infection, so EBV infection. So that is the virus that, a lot of you probably had mononucleosis when you were teenagers, for instance, where you had, fevers and bad sore throats and that sort of thing. There is a thought that it is very difficult to get MS if you've not had Epstein-Barr virus infection. And so there was a very detailed study that came out about 2 years ago looking at this. And the reason it was of interest is that Epstein-Barr virus will actually infect and then live in the B cells, which again are a very important type of inflammatory cell in MS. So what the study did is it looked at people who are in the US military, just because every year they have to get blood draws to track different, exposures to things. And then some of that is saved for research purposes. But it looked at patients and said, what percentage of these people, starting at age 18 had evidence of Epstein-Barr virus infection? So when you get Epstein-Barr virus infection, your body creates an immune response to it, just like it would to the flu or COVID or whatever. And you will then have antibodies in your blood against Epstein-Barr. So we can basically tell who was exposed to it and who was not. And then tracked those patients and those blood samples over time, and then looked at who ended up getting MS and sort of when did they get it compared to the Epstein-Barr virus infection. There's only one patient out of dozens that developed MS in the study that managed to get MS without having evidence of having Epstein-Barr virus infection, prior to the diagnosis. There's a missing link there. So one is that, often the Epstein-Barr virus infection is happening like, 7 years to decades before people develop MS. So it's not like you get it and you get MS like right away. And the other thing is that, like, by the time people in the US are hit college age, like 99% of them, whether they've had mono or not, have had Epstein-Barr virus infection. So there may be some genetic component to, some sort of piece of making that link between those two conditions. We just are not sure. So I think we may learn more about that in a few different ways. There are vaccines to help prevent Epstein-Barr virus infection. Those predominantly were designed because Epstein-Barr virus infection is associated with a lot of other diseases besides MS, including different types of cancers. So at some point we may, if we see a study of using Epstein-Barr virus vaccines and then suddenly MS rates go way down in that population, that would certainly support the hypothesis that it was an important trigger of the disease. The issue with that is MS is not common. Epstein-Barr virus is that, to do a study for that purpose, just looking at MS, is that it would require like 50,000 patients, which is not, really feasible to do from a financial standpoint. There's also a lot of concerns about just, side effects of different vaccines. You may have, thought about with hearing things about side effects of COVID vaccines and whatnot. The other things that have occurred, or there have been a few studies with some specific therapies trying to focus on cells that may be impacted by Epstein-Barr virus. To date, those have been very small and have not proven to be effective, but that may be something that we will see in the future. The other environmental triggers, other things that I get concerned about with my patients when they ask about, family members or things, what is their risk for MS? So things that we know are risk factors, vitamin D deficiency, high salt diets, childhood obesity, and smoking. So those are all things that are potentially modifiable as far as factors influencing the disease. Okay. All right. So this next question I will try to paraphrase. So it says, I have had MS for 20 years. I have been told that I am past the inflammatory part of the disease. It was described to me like the house was on fire and now you are left with the remains after the fire. I am told I have less brain volume than a normal person for my age. Should someone pass the inflammatory phase of MS be taking something to slow down the crumbling of the house? And if so, what? And so we'll start with that. And there's a few questions about this simmering MS or smoldering MS. I think these are all sort of going after the same thing. And then there's one at the end here that says, my neurologist said I did not need an MS drug or MRIs because MS burns out. Is that true? It brings up a few very interesting points. If we think about MS as a disease, we can describe patients sort of getting worse or developing disability in a few different ways. One way people will have more symptoms and get worse is by having relapses or attacks. So, the way I describe that is that, you're living your life over hours to a few days, you suddenly have some new deficit that occurs. And then, that may improve some over time, but it probably is not going to get totally back to normal. And it frequently has a lesion like on the MRI that we can look at and sort of correlate to the symptoms. So that is how most patients, that's sort of the relapsing remitting MS. That's how most patients present and end up getting diagnosed. The second way is this progression or sort of slow worsening from inflammation. That sort of is the primary progressive where people don't ever have an attack, but they notice over many months that, something's not working. Often they notice with their gait, for instance, that they're not able to walk as well. They're having falls, etc. I think historically, we have also described what we call secondary progressive MS, where people have relapses, and then eventually will also start to slowly get worse over time. I think we've sort of have moved away from trying to break all things down into those categories. So I really think of it as, are patients at risk for having relapses or attacks, and then are they having this slow progression? Because I'm not convinced that the inflammation causing a primary progression is actually any different than the inflammation causing secondary progression. And then the third way that people get worse is the stuff that we alluded to before with cardiovascular conditions and things like that. So, we do all have some amount of decline in our physical function and our mental function, like as we get older. So it's always important to think about things that are not MS that are making people do worse over time. So I think, we think about managing that, the lifestyle stuff is probably most important for that third thing that we talked about. If we think about preventing worsening from attacks, like, we're very, very good at doing that. So, the B cell drugs, Tysabri, others, I can put a patient who comes into my clinic with a recent relapse, on a B cell drug, and be very confident that after a few months when it kicks in that they're not going to have a relapse again, they're not going to have a new MRI lesion. So those are like, those drugs are total home runs as far as stopping that aspect of the disease and reducing that risk. We have a very good understanding, why those drugs work is because those B cells or that type of inflammation from the adaptive immune system is driving it. What we do not understand nearly as well is for the slow worsening that happens that's from inflammation is what sort of immune system cells are actually causing that to happen. We seem to know that those B cells are important, but they're not the whole story, because if we, kill them with the same drugs we use for attacks, we see that often the progression will slow down, but it doesn't typically just stop. So there's probably a lot more going on as far as immune system cells that we have not figured out, what they are and how to directly target them with medications. And so that is where that, the drug, for instance, that I talked about at the beginning, tolebrutinib, which is a BTK inhibitor, if there's an impact from some of these other types of inflammatory cells or microglia, for instance, it may give us a new avenue to sort of, treat that aspect of the disease. That is often, so this sort of slow progression is often, what has been marketed as like smoldering MS or simmering MS. So I think, the challenge with that is that we don't really understand the biology. It's not, I wouldn't really say it's necessarily like a totally like distinct thing that we could break down. So as far as drugs for that and treatments, right now we sort of focus, Ocrevus is technically the only drug that's approved for like primary progressive MS. So we loop those things together, that would be potentially an option. There are some drugs, approved for secondary progressive MS. A lot of those are with patients that have had more recent relapses, for instance, where we saw the benefit. We'll see with some of the new studies, sort of, how well that holds up. So I think, answering some of these, so MS burns out. So I think, yes and no. So we, have a pretty good idea that that inflammatory aspect with the B cells, for instance, that causes attacks, we have a pretty good idea that that may not totally burn out, but that risk for those attacks reduces over time. Typically after 15 years of having the disease, or if you get diagnosed with MS at about, a normal age of about, 30 or 35, we see that rates of relapses, even in patients who are not treated, will reduce. And that has to do with what's called immunosenescence. So all of us have our immune systems get weaker as we get older. That's a natural thing that happens. So that is definitely true. It's not 100%. So I definitely have patients that come in and are, have had MS for, 30 years and are 70 and have had a relapse. It's not 100%, but the risk definitely decreases over time. As to if that means someone should not be on a drug, that's a little bit of an individual decision. I definitely have patients that, are older, so in their 70s, and if they're tolerating the medication, I'll keep them on just if they're really worried about having a relapse. Although the risk is certainly lower, just based on age and not having a relapse for a while. I would argue though that like the MS is probably not burned out if you're still getting worse from it just because of these other types of like, the smoldering MS. I think we just, sort of use that as an excuse because we have not as a field figured out how to target that part of the disease adequately. Yeah, we could talk a lot about that question. I think the other part of this, it says, at what age would you recommend that someone with a secondary progressive MS discontinue use of any disease-modifying therapy? It says, I'm 55, diagnosed at age 45 with relapsing MS, but soon after secondary progressive MS. I'm doing great with Ocrevus, back to walking and feeling good. I really watch my diet as well. So that again is a very individualized decision for anyone who sort of followed some stuff from our group over the last few years. Dr. Corboy, who has been the director of the MS Center for a while, did actually a study called DISCO MS, which was looking at discontinuing therapies. So the tenet behind that was what we had talked about just a second ago, is that the longer that you've had MS and the longer you are from a relapse and the older you are, all predictive factors that you may not have as much risk for another relapse. So if the drugs that people are on are really working for relapses and not for that slowly worsening symptom piece, you may not need the medication. But like I mentioned, of course, people are also worried. If you've ever had a relapse and ended up in the hospital, it's often very hard to say, I want to stop my medicine. You can imagine there's other reasons sometimes that come into the decision making besides just the clinical piece. So, some medications are expensive, some of them are very unpleasant to take, some of them have dangerous side effects. So those are often also pieces where we're trying to weigh the risks and the benefit. So the discontinuation study, basically took patients who had been stable for several years, who were over 55. The average age was 64 in the study, so a little bit older. And it took half of them and said, continue your medication. And it took half of them and said, stop your medication, and we're going to follow you carefully and sort of see how well you do. It was set up as what's called a non-inferiority study. So because there may be benefits, safety, cost, convenience to not being on drug, they really just wanted to try to show that those strategies were within a certain threshold of difference. And so the study sort of had mixed results. The rates of having anything bad happen were very low in either group, but it did not technically fall between what we call the non-inferiority margin. So really where that comes back to, is based on sort of how people are doing, what drug they're on, what side effects they're having, all leads into the timing. And I think 55 often comes up just because there's very little data on using MS drugs, in clinical trials in patients who are in that age group or higher. So, personally, if someone that was 55 came into my clinic and they were like, I'm on Ocrevus and I feel great, and their labs look good and they are not having any side effects, I would personally probably not think very strongly about stopping that at that point. If people start to get side effects from drugs like infections, or they don't like being on the medication or things, that starts to be a little bit more of a discussion about the risk benefit. But we'll definitely learn, quite a bit more about that in the next few years. Let's see, the next question I had says, are there any ways to promote remyelination of damaged nerve cells? And then what are the latest advancements associated with remyelination? So again, myelin is that coating on the brain and spinal cord cells that sort of envelops the connections and can help them sort of connect more efficiently. Very commonly injured with MS. We have, for many years been trying to figure out, in addition to how do we stop the inflammation, how do we help the brain repair itself? And that has, unfortunately not been something that we've had a lot of success with. So unlike our trials to reduce attacks or even to some extent reduce progression, we have never had a therapy targeted at fixing the damage that has actually worked. So the most recent one was a supplement trial that we were part of with a supplement called alpha lipoic acid. So that did not work. There's been biotin. There's been another of other medications that have been out there as well. The few things that are happening right now that are of interest. So there is a medication called clemistine. So clemistine is an antihistamine drug, but some of the same receptors are located on the oligodendrocytes that help to build the myelin. And so that is being used to try to help with repair after optic neuritis, which is where MS will attack the optic nerve. So that has had some promising data. We don't know for sure that it's going to work. It's in a phase 3 trial for us to tell, is it going to be helpful or not? We'll get, stem cells often come up a lot in this context. For probably the past 25 years, there's been a lot of promise just based on laboratory understanding of stem cells. Could stem cells be used to replace damaged cells in the nervous system? Could stem cells, release positive growth factors that help you repair the nervous system? The answer is that they might, but that there still is no proven benefit to any sort of stem cell therapy for regenerative purposes. Right now, probably the best designed MS studies from that standpoint have only completed what's called a phase 1 trial, where stem cells are given, a number of what we would call biomarkers are measured to see, what are they doing, and then are they safe? But there has never been any, study completed that shows that they're actually helpful from a clinical standpoint. We hope that those pathways continue to move forward, but they, right now that is just not a proven thing. The next question says, will MS be cured? If yes, what is the time frame? And then what is the latest news in curing MS? So that's a tough one. I would say maybe. Time frame, I'm not sure. I think the big things are, if you look back, to MS drugs and history, we had no treatments for MS that were targeted to help with the disease until 1993. So we knew people had MS for hundreds of years. We literally had nothing until 1993. We had no high efficacy drugs that really made a dramatic difference for patients until 2004. We could not use that drug, which was Tysabri, broadly until 2012. And then we did not have a drug that was high efficacy that we could use for most of our patients until 2017. So we've made a lot of progress. I think I don't know that this is going to be a cure for MS, but I think the thing that you'll start to hear a lot about is something called CAR T therapy. CAR T sounds a little bit like science fiction, but it's an idea that we have stolen from the hematology, so blood cancer doctors. And so what CAR T is doing is it will basically take out T cells, so part of your immune system that can go target very specific things in the body. And then the T cells will, in the laboratory, be engineered to attack the types of inflammation that we think are important with MS. At the moment, what's being developed is similar to the targets of the B cell drugs. So you then get these infusions back of these engineered T cells, and those T cells go in throughout your body and kill all of the inflammatory cells, is the idea. The thought is that because they're cells and they're not big antibody drugs, like Ocrevus, for instance, is that they may be very, very efficient at killing all of the MS-related inflammation, and it may actually sort of reset, the immune system, back where the MS is not there anymore. So it's in some respects, it's sort of a similar idea to stem cell transplant, which I'll talk about in the next question. We don't know that it works. I'd be very surprised for relapsing MS if it did not work. I think, the question is sort of the safety profile, just because when these products are used for cancer, although the dosing and targets are a little bit different at times, they can have a lot of sort of off-target and inflammation-related side effects. But that will be very interesting for us to think about. We've seen a lot of positive results with these drugs and things like lupus and small studies, which is also an autoimmune disease, as well as a neurological disease called myasthenia. We're very hopeful. We have actually one CAR T study that is currently running at the university, and then there's at least one other one that will be coming down the pipeline in the next several months. So the next one I have, it says Selma Blair did a stem cell procedure and went from a cane to walking and dancing as if she does not have MS. I hear a lot of great stories about doing this procedure. Why is stem cell transplant not a go-to for other patients? It seems to work and people do well for many years. I understand there's no guarantee, but why is this not for everyone? Pros versus cons. Stem cell transplant, to sort of piggyback on the previous issues. Stem cell transplant is literally using chemotherapy similar to cancer to kill the entire immune system. So the stem cells are not really the treatment. The chemotherapy is the treatment. We use the stem cells to sort of regrow everything, hopefully without the same triggers that would lead to MS to develop. I don't think there is really, much doubt that stem cell transplant is a very effective therapy, for relapsing MS. There is, a large amount of data from using that in different settings, and it sort of right now serves as our backup option if people have, failed or continued to have a lot of attacks despite, the therapies that we currently use. I think the questions, with it at the moment is it actually better than the current high efficacy drugs that we have? And the answer is that we are not sure. And that is why there's a clinical trial, which is called Beat MS, that we are part of at our center, that is basically comparing best available medical therapy. Some of the drugs that we talked about, so Ocrevus, Briumvi, Mavenclad, which is cladribine, Kesimpta, which is ofatumumab, rituximab, which is Rituxan. So patients will be randomized. Half of them get that treatment. One of those treatments, half of them get stem cell transplant. Because we don't know that stem cell transplant is actually better than being on one of these other drugs. In fact, if we look at the places where a lot of these transplants have been done, so Australia and the United Kingdom as two places, it appears that stem cell transplant may be marginally slightly better than Tysabri, but with the available data with Ocrevus, for instance, it did not look like it actually was a better treatment as far as reducing risk of disease activity. They do have very different profiles as far as risk. So stem cell transplant, the risk is very much front-loaded, meaning you get the transplant, there's a very significant risk of getting very sick from the transplant just because you kill the entire immune system. You can get side effects from chemotherapy. But then you're, at least in the ideal situation, then you are off treatment once you recover from the stem cell transplant. So if it sort of actually reset everything, then you are, probably maybe good for many years. Maybe you're cured of MS, for instance. None of our other drugs, are like that in the same respect. So, we go on Tysabri, we're then on, people are on Tysabri, basically like right now indefinitely. So whatever risk or downside you have of Tysabri, you're seeing that like, every month, as opposed to having this chance to sort of like, be off treatment. Cladribine or Mavenclad is the one, differing point to that. So cladribine is, sort of like a, stem cell light. It kills lymphocytes that are driving inflammation. You get cladribine for a course over basically separated by a month, and then the same thing again a year later, and then people are often off treatment for a few years. At least the problem with that is we don't think it's probably as durable as a stem cell transplant, meaning that at some point the MS might come back, and we don't really know how to predict that. That's probably one of the issues with that medication, but sort of leads to some things. I'm not super familiar with Selma Blair's medical history. My understanding is that she actually is on received cladribine now after the stem cell transplant. I don't know if that meant that it did not work the way that they wanted or what, but it is just an interesting point. It is true that it is an expensive procedure. It depends a little bit on how it's getting paid for and when, but it may not be more expensive. We sort of count, being on a different MS medicine for 20 years versus paying for everything up front. and that, if it actually was more effective, whatever benefit we get from people working and not having symptoms. That just is a very, difficult calculation to make. It's a very good question, though.
I do have a few questions from the audience. Are there any considerations when getting vaccines such as flu or COVID?
That's a little bit of a nuanced question. The answer is it depends a lot on which drug someone is on. In different ones, we have different vaccines we have better knowledge about, and then different drugs we have better knowledge about. So there are drugs that probably do not impact vaccinations at all as far as how effective the vaccine is. So drugs like Tysabri, we don't really expect any negative impact. And the thought always is that why we're worried about it is that if we're manipulating and reducing the immune system, is that you need an immune system to basically have the vaccine work. So your immune system needs to recognize the vaccine and create a response to it that will then help you fight an infection in the future. The B cell drugs, so Ocrevus, Kesimpta, those drugs. There is some data for different vaccinations that they may, still work but not be quite as effective. So that study was done with Ocrevus, so including like influenza, for instance. It still is worth getting, and we think that the responses of the immune system, a lot of them are still intact. So that that probably applies to all of the other B cell drugs as well, like rituximab and Briumvi, for instance. COVID vaccines, for whatever reason, seem to be particularly like vulnerable to not working well. I don't know, why that's the case. So we still recommend that everyone get the vaccines, and they do work. They just don't work as well as they would otherwise. There's not a great way to time them. That's another question that we get a lot. Because those B cell drugs all work by keeping the B cells killed indefinitely. There's not a great way to say like, oh, get the vaccine like a week before your infusion or something, and it's going to work. You probably have to be off of the drug for closer to 9 months for that to actually matter. Yeah.
Sorry. Do they know yet? Have they had time to do research? Can the COVID vaccine make it more probable to get a flare?
That has actually been, fairly definitively answered, and the answer is no. But we have to be very careful to explain what we are talking about. When people get flares of their MS symptoms, there are flares that are related to brand new inflammation from the MS, and that is not associated with getting a COVID vaccine in any meaningful way. People with MS will also get what's I would call a pseudo flare or a pseudo exacerbation, where they will have their old symptoms get worse due to some trigger, and then they'll get better. The MRI will not look different, and they'll get back to normal after a week or something like that. So pseudo flares are actually very common to occur after a vaccine, just because it can make you sort of feel crummy, just because it's revving up the immune system. So in that case, it's very similar to if someone with MS were to get a urinary tract infection or pneumonia or something, almost always the old MS symptoms are going to feel a little bit worse, at least during that illness. And that is not because of new damage. It just is like putting a stress test on the damage that's already there. But the only vaccines that I have concerns about, not about triggering MS flares, but just about safety for people who are on immunosuppressive therapies are live vaccinations. We don't have a lot of live vaccines anymore, but like the chickenpox vaccine, for instance, yellow fever vaccine, Japanese encephalitis for people who are traveling to different areas. We don't like to give live vaccines when people are immunosuppressed, because then the vaccine contains active virus and it can actually make you sick. But shingles vaccine, flu vaccine, COVID vaccine, Prevnar, which is the pneumonia vaccine, the RSV vaccine, which is now recommended and new for older adults. Those are all generally safe to get.
And I will say in our last issue of EMS News, our monthly newsletter, we did send out an article on guidance for the COVID and flu and RSV vaccine, including timing in relation to specific drugs. So if you did not get that, feel free to send me an email. My email address is just education@mscenter.org, and I'll send you a link to that article. And then we did have another question from the audience. How often do you recommend having an MRI if you've been steady on Kesimpta for a few years?
Yeah, it's a little bit of a, also depends on the patient's sort of situation. So a lot of practices and guidelines for MS will say to get MRIs, every year. I personally, and I think again, most of us at our center will typically, at least early on in the disease, get at least a brain MRI every year. We frequently do not constantly yearly repeat spinal cord MRIs. Again, out of the idea that the spinal cord is very small. If there's new disease, like you're, probably 80 to 90% of the time going to have a new symptom. And I think in the context of Kesimpta, which would also, apply to Briumvi and Ocrevus and Tysabri, is that, the chance of having a new MRI lesion, just on Kesimpta, since that was the question that was asked, if you've been stable for a few years, is very, very small. So I typically do try to still get an MRI once a year, but if my patients are very minimalistic, if they're having trouble, affording the MRI, if they've been clinically stable, have not had MRI changes and they're on drug and feeling well, then I will sometimes space it out to every other year.
How might AI impact MS research and treatment?
Also a good question. So there's a lot more AI tools, especially being used for in radiology, so to help with MRI analytics. So including some stuff that we are bringing on board at the university. So looking at things like brain volume, for instance, and actually counting lesions and measuring lesion volume. So there are some AI tools that can actually do that, much more effectively than we can as a clinician. So I think that is one, thing that might be very helpful.
We only have a couple of minutes left, and so I wanted to make sure if anyone in the room has any questions or anyone online. Final questions. There's a paragraph in here. Let me see what it says. Lots of comments saying, thank you for the evening. Really appreciate your explanations, and going to continue researching. So thank you for everything tonight. Take a final look around.
Did you say something about the ALA vitamin not being found to be effective?
So there's a supplement being studied to help, especially with walking in MS patients, called alpha lipoic acid, and that did not work.
Does it help anything else?
Not as far as we know. Again, this is one of the problems with a lot of the MS therapies, more for symptoms or neuroprotection, is because MS it has a propensity to damage motor pathways. It's often, so much of what we do is based on walking function, right? So just because it's an easier thing to measure and it's frequently impacted. So we cannot, we often do not, unfortunately, test every aspect of nervous system function with everything that we're trying. So we sort of use that as our proxy. That's sort of my argument with that other drug with Ampera, is that there's really not a reason that it would only, do things for walking if it's impacting all of the brain and spinal cord cells. But yeah, it did not look like with the outcome that was helpful, though, unfortunately.
They recommend concerted things for ADHD, but also for do you recommend any stimulant drugs, or is it more that you have to have that qualifier as well?
Yes and no. It depends a little bit on the issue. If it's more fatigue, I tend to prefer drugs like modafinil, just because the side effect profile and like the addiction risk is a little bit lower than with things like Adderall, for instance. But I definitely do have patients that we try things like Adderall for fatigue and cognitive issues. There's not a lot of data, and we don't have a lot of studies like looking at these things. But anecdotally, there definitely are people that benefit from it.
About the high intensity interval training that, I know that a lot says moderate exercise, but do you have any feeling on that, or if it drains you more, or if it does give your body that boost?
Yeah, I think any sort of exercise program that people are willing to do reliably is helpful. So definitely like I have patients that do HIIT, for instance, that like really think that it's useful. So the biggest thing is just doing something as far as engagement. I don't think we'll ever have a study that is going to compare like different exercise programs and which one is better. So really anything I think is beneficial.
All right. Thank you, everyone. Thank you guys for being here. As we wrap up, I just want to remind everyone there are evaluations on the table, and there will be a link to our evaluation in the chat. I really do take all of that feedback to heart. I read through it all. You inspire many education programs, so please fill those out. If there's anything tonight that I'm talking about or that Dr. Wolf has talked about that you want more information on, feel free to leave me a note in your evaluation, or again, my email address is education@mscenter.org. I'm going to point out a couple of upcoming things or resources we have. I just want to reiterate the Ed Summit topics that are coming up on November 16th, because those came up a few times tonight. The updates that Dr. Wolf talked about in the beginning on diagnostic criteria and BTK inhibitors, we'll have a presentation on that. We'll have a presentation on the CAR T therapies and a presentation on aging with MS, as well as invisible symptoms, which includes fatigue. Our next issue of Informs, which will be coming out very shortly, has a spotlight on stem cells. So if you want to read a little bit more about that. We also have a lot of material on the DISCO MS study. So Dr. Corboy has done webinars for us, Informs articles, all sorts of details from that study. So you can either search on our website for DISCO, or I can email those to you. And then that vaccine guidance that we gave in EMS News. So again, thank you all. Thank you, Dr. Wolf, for your time, and have a great rest of your evening.